neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
In order to prevent the spread of the virus, we all need to do our part. One of the easiest ways to prevent that is by wearing a mask. In order for a mask to do its job, it needs to cover your nose, your mouth, and your chin. First, you should wash your hands with either sanitizer or soap and water before putting on a mask. Then pick up your mask by one of the ear loops to make sure that there's no tears or stains on the mask. If it is dirty, throw it away immediately. If it's intact, take both loops and put it over your ears like this, and then press down on the bridge of the nose to make sure that it fits and there are no gaps. Once you are done with the mask, please take it off the same way. Both ear loops, pull it away, and put it either in a Ziploc bag or throw it away if it's a surgical mask. If it's a cloth mask, make sure to wash it with soap and water and keep it dry for the next use. Do not put your mask down at your chin or above on your forehead when you're starting to remove it, as that just contaminates the mask. Thank you so much for doing your part to prevent the spread throughout the city.
When someone is having a stroke, it's all about how fast can you get to treatment. The title of this program is called Time is Brain, and the acronym B.E.F.A.S.T. We'll talk about that in just a minute. During this next hour, we have experts talking about strokes in all kinds of people, not just those who are at high risk. There are strategies and treatments that can not only save lives, but really improve the quality of life once you've had a stroke. As you know, this is a live show, so think of some questions that you'd like to call in with this evening. The number is 881-0013. We are streaming live on YouTube. Just search for PBS El Paso and the El Paso Physician. This evening's program is underwritten by Tenet, the Hospitals of Providence. And we also want to thank Texas Tech Paul L. Foster School of Medicine for providing the medical students to man our phones. This evening, we have Madeline Morris with us, and she's already been testing and making sure that questions are coming my way. So thank you very much, Madeline, for joining us. We also want to thank the El Paso County Medical Society for bringing the show to you each and every month. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Strokes, it's loaded because there are different kinds of strokes. There are also brain bleeds. There's hypertension. It's part of the cardiac system. It's part of the neurology system. And we've got a lot of information here for you this evening. We have a veteran with us, Dr. Kenneth Berumen, and he is in emergency medicine. And then we have Sin, which actually is Cynthia Ann, and I love that. Sin Little is with us, and she is a neuronurse practitioner. And she is a neurointravascular nurse practitioner. I just like the way that's put together, and it helps explain what we're talking about here this evening. It's something that sounds simple, but when we talk about emergency medicine, because you think of strokes, you think of heart attacks, you think about all the stuff that you see as the emergency doc, what is it that you'd like to explain to the audience that you do in the idea of the topic for this evening, but also what you do all day, every day?
So what I do every day is just see people that have unexpected illness. And so that's what we as emergency medicine people do. As far as stroke goes, we really look at the time of onset is the big thing for us. Mm-hmm. And getting you to diagnostics and then getting you to treatment as fast as possible. Because as you said, time is brain, and every minute you're losing 1 million neurons or glial cells, the cells that help keep that structure together. So literally time is brain.
Okay, so every now and again you guys say something, I'm like, I haven't heard of glio cells before. So you said the glio cells are helping to...
The glio are structural cells, so it's kind of like the frame to your house. Mm-hmm. So it keeps that stuff intact.
Okay, so that's what's happening. Every minute those start dissipating and everything else.
And the actual cells that actually do the brain work.
Okay.
You're losing both those cells at 1 million a minute. So
okay.
That's a huge amount of tissue that gets lost very quickly.
So again, it's all about the time, and if you just think you're having a stroke, or if you see somebody you think is having a stroke, and we'll talk about a lot of those symptoms and risk factors in a moment too. Sin, I feel so groovy saying that because everybody's calling you that. So am I allowed to call you that?
Yes, ma'am.
Thank you. So you're a neuro nurse practitioner, again, intravascular specialty. What does that mean to the people at home?
So basically I work with 5 physicians, and so our job really is when patients are coming through the ED, we're looking for large vessel occlusion. So If, say, they're having a stroke, we'll do the head CT and the CTA, and that kind of gives us more information what kind of stroke they're having, ischemic versus a hemorrhagic. And we basically work for the large vessel occlusions. That's a large clot that's in one of the main, like the MCAs, the carotids, the ACAs, and my physicians can take them to the neuro lab, and we endovascularly will remove that clot.
Okay. Actually, I usually would ping pong over to Dr. Baruman, but I'm going to stay with you for a second because I'd like to, like, right in the get-go from the show, define the two major types of stroke. So you mentioned them. There's a hemorrhagic stroke and an ischemic stroke. What is the difference between the two? And then you can go right into very different treatments of the both.
So ischemic strokes are strokes that basically your blood vessels in your brain are occluded by either clot or plaque. So then you have decreased circulation, blood circulation through the brain. So then you have that brain or the tissue damage, right? The hemorrhagic strokes are the ones where your blood vessels in your head somehow they rupture, like from an injury or from a aneurysm, and so then it causes you to have like a hemorrhagic stroke or blood in the brain.
Okay, and so here's that difference that I feel like in many of these shows. You also hear about people that have brain bleeds, but it's not necessarily a stroke. Is there a way that you can explain that to where, because a stroke really is, like you can recover from a brain bleed that wouldn't be having to recover from a stroke. And I don't know how else to ask that question. Because I think of a hemorrhagic stroke, but it's still a stroke. But a brain bleed, what is the difference between there? Or is it one and the same?
It's
pretty much one and the same.
Yeah.
Okay.
There is a difference between
Different
what's called a
hemorrhage.
subdural hematoma,
Maybe that's what I'm
which
thinking
is
about.
kind of
Okay.
a bruise between your skull and the covering to your brain.
Okay.
That usually happens in elderly people that fall, and it causes some compression. Still, that compression, whether it's be a hemorrhage or it be the subdural, that compression also decreases the blood flow to that part of the brain.
I see.
So it
Okay.
can cause damage.
Okay.
So anything that's causing a lack of blood flow to any part of the brain is really causing a stroke.
Okay. So on that note, as the emergency guy, we have somebody coming in now, and you can use case studies in the past or what have you, but what are the most common types of strokes that you see coming into the ER?
Paso is probably ischemic stroke.
Okay.
That's the primary one. The diabetes and hypertension, they're two much more amenable, shall we say, or unlucky to get it. So that's what I definitely see more of. You do see some hemorrhagic strokes, but for the most part, it's ischemic strokes.
Okay, so if you have an ischemic stroke, somebody's coming in, and let's say luckily they're with someone, they're with an hour, let's say from the onset of the stroke, and I'd like to maybe now with both of you kind of go through the time. So maybe somebody's there within an hour, within 2 hours, within 3 hours, and what the differences are with those time lapses when when they're finally able to get to you.
So the first thing I would say is anytime you notice anybody having these symptoms, is you're dialing 911.
Okay.
That's how important this is. You're not waiting to see if it gets better. You're not waiting to see, are they going to get worse or come back? Because all that period of time is getting worse. The longer you wait, the more tissue you lose. So what we do essentially, oftentimes we're going to ask you, come in via 911. That's what the service is there for. They're going to get you to us faster. When we get them from 911, the 911 service calls us, they tell us it's a suspected stroke. So we activate the team, we clear the the CT scanner, and we get ready to take this patient through. The patient comes in, as long as they're breathing, they go straight to CT scan. So we start doing the study there. And at our facility, what we have the ability to do is go over and actually assess the patient within the CAT scan. And we also have what's called Tele Neurology. So we have a neurologist that's going to be a specially trained neurologist to take a literally at the video screen right there in the room where you're getting scanned.
Nice.
So everything happens very quickly, including we have pharmacy there in case we need to give you the blood, the blood
thinning,
clotting there.
right, yeah.
And we have lab there to draw your blood, and so everybody comes in. It's pretty much as we would think of a trauma team when they bring in a trauma. Well, this is a stroke team when you bring in a stroke, so everybody
Right.
jumps right on it.
So I like what you said too, call 911, and this is where I think it's so important. I'd love for you to both of you to kind of talk about how important that is, because once you're in the ambulance can call in as they're driving you to the hospital and give a lot of this information ahead of time, which is something you can't do when you're in a car or your partner's in a car driving. Because some people think, oh, I can just drive myself, or I can get my husband a driver, whomever. So 911 is so important, and if there's anything else you want to sell there,
I think that's the big thing is 911. You're not going to call your husband and say, hey, my face feels droopy, or I can't move my right arm.
Right.
The key is, you know something's wrong, and the key is just call. The service is there. Plus, they run what's called Code 3, meaning they get to run through traffic lights. They get to get you there faster. Your husband or spouse or your next door neighbor is not going to be able to do this.
Exactly.
And if you go bad on them and you can't breathe any longer, guess what happens? Your neighbor's going to feel horrible. 911, we know how to take care of that problem. So we can help you all the way through the process.
I like how you said that. Guess what's going to happen? You're not going to die. Your neighbor's going to feel bad. I kind of like the way he said that there. And Dr. Baruman talked a little bit. And Sin, if I can have you talk about, again, sometimes you don't know somebody's having a stroke. Sometimes they themselves don't know they're having a stroke. So symptoms you talk about, drooping, you're slowing speech, etc. Throw out as many things as you have seen happen with people that have come in. It's like, well, I wasn't sure. We could talk about some of those, because that is sometimes, well, do I call 911? Do I not? Will this just go away? Talk about some of the other symptoms too.
Well, we use the acronym B.E.F.A.S.T, right?
Yes.
So B means for balance. Sometimes patients or an individual has trouble walking, they're dizzy, right? So E is for eyes, so vision changes. Sometimes we've had patients lose vision in one eye, and then within a minute or two, it comes back, they think it's nothing, and that's kind of precursor to a stroke. Double vision, blurred vision, so any visual changes, it's not normal, something's going on, right? Okay. The F is for facial droop. So sometimes a family member says, oh yeah, I saw that they had a little drooping at the corner, or they were kind of drooling. It went away within 10 minutes. So that's kind of a telltale sign. You'll see the drooping.
F-A?
The A is,
Yeah,
I'm like, how do I spell? No. A is arm or leg. So sometimes they'll have some weakness, or they totally go flaccid, right? They can't move, or they're picking up their cup and then they just drop. So I've had patients before say, well, I was in the kitchen, I picked up a cup, it totally dropped, I didn't think anything of it. That happened the day before, and then the next day it gets worse, right?
Okay, right.
So S is speed. Slurred speech, right? So sometimes they have slurred speech, they have trouble speaking, or they're trying to speak and nothing's coming out.
Okay.
And then T is for time, so immediate, like he said, Dr. Baruman said, call 911, because these are symptoms that can get worse. Sometimes they do get better.
Right. And that's interesting when you said, somebody dropped a cup and, and then the next day they're at that point. And I guess this is where I'm coming to, because I know we want to dedicate time to time tonight. If someone has, let's talk about mini strokes. Like there's mini strokes, mini heart attacks. I feel like nothing's a mini stroke. But when you hear people say that, what is that physiologically compared to a major stroke? And I know I'm not using the right words, but you will hear that right and left. A mini stroke, a major stroke. How would one explain a mini stroke?
So we call those TIAs, or transient ischemic strokes, right? So sometimes they're just precursors to a big stroke, right? So a lot of patients that I've seen in the hospital when I'm, they've been admitted and I'm doing my history, they'll say, oh yeah, like a week ago, I kind of had the drooling, or my spouse noticed that I seemed a little confused, or I was a little numb. I felt numb and tingly on my left arm, and now today I couldn't move it. It kind of made me, kind of upset. I was dropping the cup. So these are things that are they're transient. They usually last less than 24 hours.
Okay. And then once you get to the hospital, is there and Dr. Bruman asked you this, is there some kind of a test that you can see, oh, well, there was a mini stroke? What is it that does show up in tests, if anything?
Usually a stroke won't show up until weeks to a month later on an imaging.
Oh my gosh,
So
really?
you won't see the damage show up on an MRI for a couple of weeks up to a month. So usually what you're going to see on an echo initially is going to be bleeds.
Okay.
So that's what we're looking for. If it's a bleeding stroke or not. If it's not a bleeding stroke, we automatically assume this is a clotting stroke. Right. So that's the big thing. So,
Okay.
and the thing I think about with sinusitis is very essentially is people will have symptoms one time and then they'll blow it off, and then the next day it's much worse. So if you have any neurologic symptom, even if it goes away, that needs to be investigated.
Okay.
So we will study you within 24 hours of any symptom and say, we're going to treat you just like you had an acute stroke.
So if you're coming in and you have an acute stroke, and let's say this is an ischemic stroke, again, you're going straight to the CAT scan. From there, what are some of the most common sources of treatment? I mean, the IV, if I remember from last time, you're trying to, it's like a declotting type thing.
Yeah, there's declotting medication that actually eats away the clot. There's TPA, and then which is Altiplase, I believe. And then the tenecteplase is the newer one that's going to be a one-shot drug that's just been approved, and some of the sites are moving forward with that.
Tell me what that is.
So it's another drug that we use to eat up clots. It's a little easier in that it's a single dose and not a drip. So that's great. I think that's going to be really helpful in our rural areas and areas that don't have stroke centers like we have in El Paso. So
Right.
we'll be able to get those kind of treatments out to more rural areas and get patients in here.
And is it an injection?
It's an injection
Okay.
also. It's an
Okay.
IV injection.
Interesting. Okay, I like the way you said that. Sorry, we've got some questions here coming in from the audience. I'll let that go for just a second. So here's a question. I don't know if anybody can really tell, but the cause of a stroke. So there are risk factors. In fact, let's start there. Let's talk about risk factors, because we were talking about here, we've got hypertension, we've got diabetes. In general, there's family, hereditary issues, but what are some risk factors for people to know, you know what, I'm one of those people that's prone to a stroke?
A lot of the chronic illnesses, right? We see diabetes uncontrolled, right? Hypertension, high cholesterol, heart disease, kidney disease, anything that kind of is vascular in nature.
Okay.
Can cause you infections, you know, can cause any strokes.
And how about genetics? When it comes to my dad had a stroke, my cousin had a stroke, my uncle had a stroke, how much is that runs in the family? I know there's a lot of behavioral issues, behavioral, you know, things that you can do, but just genetics in general.
So it's not really hereditary, it's more the risk factors, the chronic illnesses that are uncontrolled that will cause you to be at higher risk.
So this really is something that you can take on and try to prevent yourself if you
Yes,
have.
behavioral modification.
Okay.
I think the only one that you wouldn't have that control over is aneurysm.
Oh,
Yeah,
you know what?
true.
That's always
That
when it
is-
comes
that
up for
is
the show.
familiar. Yes.
That's a rarity, and yeah, sometimes people have family history of aneurysms, and sometimes it's just out of the.
See, and I think some people, I'm glad that you brought that up, because that's where, again, that gets confused with a brain bleed, with a hemorrhagic stroke. What is an aneurysm? So on that note, describe what an aneurysm, like give the definition of an
So
aneurysm.
the aneurysm is like a weak part. Think about your garden hose. And as your garden hose gets older, it gets there's too much pressure, you get this little blab on it, and it pushes out and looks like a ball on it. That's what an aneurysm is. It's a bleb on a vessel, and it's a weakness in the wall. So eventually that weakness can give way and erupt, or your blood pressure gets so high that it makes it erupt. So now you have this weakness, and your water hose is now burst. And now you're spilling blood into a vault. It's your skull that doesn't hold very much blood.
Right.
Because there's a brain in there. So it doesn't take a lot of blood to really see some damage. Within 10 cc's of blood, you're going to do a lot of damage just in that little amount of time.
So cc's is how much? If you're looking at this cup of water.
I would say about, it would be a little bit more than my thumb full of fluid.
Okay,
So
okay, that's not a lot, you're right. The brain does take up a lot of room in there.
elderly
Yeah.
patients, luckily, their brain's straight, and so they have a little more space for that. So the younger patients.
Don't tell them that their brain shrinks. What is wrong with you? Do you not know our demographic here?
We're sensitive.
We're sensitive to those kind of things.
As I speak.
No, but that's a good point, though. So there will be a little bit more fluid than in
So
someone who's a
younger
little bit
patients
older.
with a bleeding hemorrhage do very, very poorly for the most part, because they just don't have the space
Okay,
to pick up that shift in the brain.
okay. No, that makes perfect sense. And we were talking too, are there any screenings that you can do for this? I mean, we're talking about aneurysms. That is something that can run in families. And I know with coronary heart or artery disease, there's a type of screen that you can do. Is there any kind of screening for this type of a situation in any strokes, really?
You know, you don't routinely screen, and
think about
the
preventative,
gold standard
you know.
would be a CTA, right, of the head.
Okay.
but I know a lot of times when we're treating our patients with aneurysms, we do ask them, do you have family members? And sometimes they'll say yes, sometimes they'll say, oh, my father died, my great-grandfather. So if there's, you know, 2 or more, then sometimes we'll say, you know what, maybe if you guys, you know, sometimes I think, I'm trying to remember the physicians I work with, I think once or twice we've said, you know what, maybe the other siblings should get should get a CTA, only because I think there were like 7 siblings and 3 of them, like 2 have passed away and then we had 1 as a patient. So they had a high incident in their family.
Okay.
But it would be doing a CTA or an MRI, you would see the aneurysm.
And there really wouldn't be a year when you do that. So I always think about screenings and preventative steps. Like, well, age 50 is when you start doing everything.
Yeah.
Just go to the doctor and check off all the list. But I think in a situation like this, you just look at what's going on in your family. And again, lifestyle, which you already have is comorbidity, so to speak, and all of that. I'd like to talk, you're part of this team, and you're talking about the doctors that I work with, and you have a bunch of doctors you're working with. So you are in the emergency department, you're in the neurology, vascular department, but it takes a team when somebody comes in, and again, I'm thinking emergency, I'm thinking time. Who is it that stands next to you, your team, as somebody is coming in, and you're assuming there's a stroke, or not assuming, the ambulance has kind of said, okay, this is what we're looking at right now. Who else is on that team with you, and what are they doing?
So when we're calling, it's the physician, there's 2 nurses, there's a phlebotomy check, there's the administrator on duty, there's a CT check, and then we have our Tele Neurologist that is all involved. So all these people kind of come in the room at the same time. We all try to work at the same time. And the key, again, is we're going to try and push you to that CAT scanner as soon as we can. We're doing most of that work in that room so that we can get to see what the brain looks like. So it's about 7 or 8 people that come in. It's a little intimidating. You call contact and the patient is already a little freaked out, and then you have 6 or 8 people rush.
I'd rather have 6 or 8 people there instead of 1. I think I would kind of feel that. So I'd like to talk about relieving pressure. I know that we're talking about ischemic, but like hemorrhagic strokes. And there's bleeding in the brain, whether it's an aneurysm, there's pressure in there. How is that pressure relieved? You have to go in there and release some of the pressure, take part of the skull. I know I'm getting gory here, but it's interesting to me. It's fascinating to me.
There's various ways to do it. Typically, you put what's called a ventriculostomy in. It's a bolt that goes into an area of the brain that's called the ventricle that has fluid in it, and you can extract some of the fluid that way. If it's a subdural hematoma, then you can burr a hole and let the blood out that way. So, but a lot of times it's a matter of just controlling the bleeding and not necessarily going in and taking out the blood, because the blood oftentimes is not a big So it's controlling that bleeding, controlling your blood pressure, so that bleeding gets controlled rather than going in and trying to stop it. Now, there are ways of stopping it. If it's an aneurysm and those kind of things, and that's what we call Sin and her team. They'll go in and do their miracles with their machinery and their catheters and those kind of things.
What a perfect transition. Let's talk about the machinery and the catheters and all the toys that you get to work with. But again, I like to kind of stair-step it for the audience of what it is that you're doing.
So, in reference to the hemorrhagic?
Yes,
So,
yes.
So, if it's a subarachnoid hemorrhage, a lot of times we'll look at the CTAs. So, my docs will look at all the films and kind of see. Sometimes they'll know where the aneurysm is because you can see it, or sometimes we'll just have to take them to the neuroangio suite and we do a cerebral angiogram. So, a lot of times
So,
we'll.
explain what that is.
So,
cerebral angiogram.
So we'll either go through one of the arteries in the wrist or in the groin, and we take a catheter, he access it, and then goes up to the artery to kind of the subclavian or the subclavian, and then we go through the carotids and the vertebrals in the back, and they kind of shoot dye, and it kind of, we see the perfusion of the brain. So then we can see where that area hemorrhage is, and he can get a better look of the ruptured blood vessel or the aneurysm. There's 2 ways, depending on how large it is, we'll either put coils in, which are like little springs, like if you know a ballpoint pen, you pull that out, but they're very, very small and delicate. Or they use stents, which is a flow diverter. So again, he uses the pipe or the hose. You have that little ruptured, so the stent goes in the main hose area, so it blocks off that bleb that has ruptured. Then over time, it just kind of adheres to the area. And so it stops that flow to that open area, and then it coagulates.
And
then
how
it
long would that
slowly-
take? So I'm trying to think of when.
So depending on how large it is, we always, if we're putting stents in and coils, sometimes we'll put them on aspirin and Plavix. Those are antiplatelets, just depending on how large the bleed is. If we put a stent in, we do have to use aspirin and Plavix, and sometimes it's, depending on where it's at, it's 3 to 6 months.
Okay, so that's a good amount of time then. Okay,
yes.
so would that be something that would help preventing in the future? For example, if somebody has a hemorrhagic stroke, is this something that they may get again? I think with aneurysms, you can see that because that watering hose, if it's not doing too well, I can see how there'd be another and another. Is that something to look out for again if you had one hemorrhagic stroke, that you're probably prone to another one, or is that not necessarily the case?
Yes and no.
Okay.
So sometimes there is, depending on, again, the risk factors. And we're always doing the behavior modification, and we'll tell them, you know, if they're diabetic, this is, you have to control your diabetes. If you're a smoker, you have to quit smoking. If you have kidney disease, you have to control that. Hypertension, you have to control your hypertension. Any of the chronic illnesses, exercise, lifestyle, like healthy diet. So these are all things that we can control. And the same with having a hemorrhagic versus a ischemic. If you've had one, chances are you may have another one, but you got to control those risk factors.
Exactly. And that's nicely put too. Doctor, I'm going to get this guy. I know the audience can't see him, but man, there's a guy that's just doing this all over the place. Thank you guys for chuckling, because I know he's been bugging you too. When we're looking at, again, the treatment, as an emergency doctor, we talked a lot about, you know, the risk factors, diabetes, hypertension, but there's a world of neurology here too that I think a lot of times we just don't think about with strokes. And I'd love for you just to address that. So neurologically, when a stroke is happening in the brain, that's what you're looking at. You're talking about neurons getting, just dying. You know, there's a point where brain is time, time is brain. Talk about that and the damages, because you think of people having a stroke, then one side of their body doesn't work. I remember that when I was a kid. My mother's, you know, friend had a stroke, and that's what I remember. So in my head, that's what I always think. It's like, it's a huge neurology thing, but we don't talk about that in prevention. And I don't know if that is a prevention question.
Well, I think it's lifestyle changes and just healthy things that you should go see your doctor every year. You know, get your blood pressure checked, know what your risk factors are, avoid smoking. In youth, those people that think they're youthful and using cocaine, that shoots your blood pressure up and it ruptures aneurysms. I mean, it's just a matter of being wise and thinking about your health overall. These ones where they don't move their arm forever, that's oftentimes a large vessel occlusion, which is what Sim's team comes in and does, so that you can get that movement back. So oftentimes you can tell, this looks like a large vessel occlusion right off the bat. You know, they're staying off the one way and their body's flaccid in another. I can tell right away. I'm going to call her team, because that looks like a large vessel. So after a while, you get to recognize strokes as they come in.
So again, you're good at transitioning, because now I'd like to talk about, because I don't feel like, at least the last several shows that we've had regarding strokes, that the quality of life and the rehab after certain strokes has really changed and been dramatically better over the last decade or so. What is it now that you are able to do to help regain some of this neurological damage? And is that even possible, actually, neurological damage? But I know that there's rehab and trying to work things through. So talk about what your team does after a stroke.
I think, again, we go down to the basics. You start having numbness, tingling, or any of these symptoms, getting to the hospital quickly, right? Calling 911 and getting so that you can be treated. The quicker, the better. And whether it's a small vessel or a large vessel, we're able to remove the clot or help. It's multidisciplinary. So speech and occupational therapy and physical therapy are working, if not later that same day, at least the next day. So we're getting them out of bed, we're moving them, and it's very aggressive. And you know, we don't know within 24, 48, 72 hours how much damage is, because sometimes a stroke can still kind of expand and some of the tissue can still die. But it's just that hurry up and training your brain to get moving. Right. Especially, you know, communication is key. So we're already, you know, even, let's say we've done endovascular treatment. Let's say they did it I had a patient, they were doing it in the morning, right? So he did it like 3 a.m. and I'm in there rounding at 8. Speech is already there at 9, and he's exhausted, but they're still working with him, trying to get him to speak. They get frustrated.
We're talking right away. This is the day that they've come in.
Yes, the faster the better, because and if they can tolerate it, right? Of course, if they're more severe, they're still intubated, they're just very unstable. So we're looking at their blood pressure, we're looking at their heart rate. So if you're getting up and moving and their blood pressure shooting up and they're very tachycardic, then we're going to let them rest. But a lot of them can tolerate it that same day. And I think that's important, is you got to train your brain again to start moving. So, and it helps them, and sometimes they get frustrated, but the more you're working at it, it's almost like sometimes you have to learn like you're a toddler. And I don't mean to, offend anyone and kind of compare them to a baby, but as an adult, especially the older, we have to relearn some things. We did have a patient who was he had a severe stroke. He had right-sided hemiplegia, so he wasn't able to move him, and he wasn't able to speak. After 24 hours, we were able to go in and remove the clot, and after 24 hours, he started to be able to speak a little better. Speech was in there. He was getting very frustrated. He wasn't able to move his arm, so they were telling him different ways to help, right? So if you don't move a limb, then guess what? It just gets flaccid. It's not going to work, right? So they were, doing passive range of motion. They were making him move it with his other arm. Every time I go around, he was doing it. He was there for about 2 weeks, and he was able to be discharged home with home health, but he was able to speak a little bit more clear.
Okay.
And he got most of his movement back on his leg, and his hand he was actually able to move it a little bit. So he was improving. Sometimes it takes these patients 6 to 9 to 1 year to recover. So it's not a quick recovery.
Right.
And we just have to reiterate to them that, yeah, you're frustrated, but these are things you need to do to get better.
Right.
And just, be
once
there
this
and
person
support
is
them.
discharged, and I guess this is something that Tenet Hospitals Providence does, is send people home. Are there people going to his home to help him then do some rehab? And maybe you can explain some of the exercises, some of the things that you are asking the patient to do. Like you were talking about, if they can't move their arm, then they would physically move the arm themselves. What are some of the other things that you teach them to do, reteach, I guess?
So case management is the one who really works on the discharge planning. So from day one, we're getting them there so that they can help them with discharge planning. What are their needs and what are the family's needs? If we feel that they can't safely be discharged home and the family can't care for them, then we try to get them into inpatient rehab. And they're doing 3 hours of inpatient rehab daily. They're tired, but it's really aggressive and it's good for them, right? Sometimes they're able to go home, like this gentleman was, and then they'll go PT, OT, and speech will go to their houses. It depends. Sometimes it's 2 to 3 to 4 times a week, or they'll go and drive there. And we basically, some of the patients, it's the movement of the arm. We're having them sit up in chairs. We're having them feed themselves with the affected arm as much as possible. Some patients, I remember having a hard time speaking. It's more slurred, so we have them read out loud so they can hear themselves. Some of our patients that have trouble speaking or have trouble kind of expressing themselves. We've had a young girl, and I can't remember why she had a stroke. It was it was like 4 or 5 years ago. Her parents bought her an iPad, and she was texting, and it was kind of helping her brain.
Nice.
So she was able to actually write, and then I think a year and a half later, she came back and she was able to speak. So we use everything that they can do. I mean, we have wonderful therapists there. We have wonderful speech therapists that work up in a rehab. We'll call them for advice. Sometimes they can't express, so then we'll get them white paper with a marker and we have them write. So just because they can't speak doesn't mean they don't understand us and they can't communicate. They can still write. Sometimes it's pretty messy, but after a while, just training them that way, that improves as well. So we try to work, every patient's individual. We try to work as much as possible with them to see what works for them.
It's very interesting too, because you also mentioned the word young in there, and Dr. Baruman, now that we've talked about the old people, we got to talk about the young people, right? We were talking a little bit prior to the show starting that there seems to be an uptick in people in the ages of 30s and 40s that are having strokes, and it's not so much the ages that you were talking about, it's some of the conditions that they're in, or if you could talk a little bit about that so people don't just think, oh, now just younger people are getting strokes.
No,
and it's
I think it's conditions, it's lifestyle choices, it's hypertension that's not, I mean, young people don't go to the doctor for the most part. They don't know what their blood pressure are and that kind of is. And there can be a person walking around that's quite young with a blood pressure that's 200 over 110 and they don't know it. You don't feel it.
Right.
So I think the key is to do routine maintenance on yourself. Avoid stuff that's going to make you get your blood pressure up. Cocaine, I see a lot of cocaine.
So you said cocaine earlier. Let's talk about cocaine. I don't think we've ever talked about cocaine on the show, so let's just throw that together. So you're talking about young people.
Yeah, people that have aneurysms.
Right.
And now suddenly you're using cocaine, it shoots your blood pressure straight up, and it ruptures those aneurysms. So stuff like that. Now the other thing that we started to see, and that was talked about a little bit, I just didn't see a lot of it, was the worry about COVID and hypercoagulopathy. That was a concern that was put out. Are we going to see a lot more strokes with this? And I just don't know the science enough to tell you, is it really true? Did we see a lot more cases? I personally didn't see too many cases like that, but I don't know enough about the literature to tell you.
And that's going to be interesting, because I talk about it a lot during this year. 10 years from now, it's going to be such an interesting book to read of what the study is from these will be 2 to 3 years, and the long-term effects. We talk about long haulers, but also in the very beginning of COVID, you heard a lot of the underlying conditions, but blood clots. And then you heard about asthma too, and it turned out that asthma that wasn't really a thing, because if you're controlling your lungs already anyway, people who are asthmatic usually have inhalers or whatever. If it's already under control, then you're pretty much going to be okay. With strokes, I'd love to expand a little bit on that, because that is the automatic thought process, that blood clots, you think about blood clots with strokes. I'm thinking here, arrhythmias, AFib, all these other, when you watch TV and there's that commercial that says, and if you have a stroke not associated with AFib, what does that mean?
So, yeah, I think the big thing with atrial fibrillation is what it is, the upper chambers of your heart are not really beating. So there's 4 chambers of your heart, the upper chambers and lower chambers. The upper chambers in atrial fib are kind of like a bag full of worms. So if you can imagine, there's bad circulation there, you can form a clot, and then suddenly that clot moves. That's why atrial fibrillation is such a risk factor for stroke, because you can form clots in these atria, and you can either go to your brain or go to your lung and give you a pulmonary embolism or a stroke. And so that's why atrial fib is such a worrisome thing.
So what causes atrial fib?
There are so many different things that can cause atrial fib. It's usually a conduction problem. It's generally an electrical conduction problem. If there's electrophysiologists that just do those studies, and they can map out your heart and find that irritable area, and they, with radio frequency, just ablate that area, so you never have that again.
I remember the first show we talked about ablation, and I remember just being blown away that that's even something you could do. I'm an AFib girl. I have a heart valve issue, so my heart's beating all over the place. Sometimes it's a butterfly, sometimes it's a freight train. But it's interesting to me, because when you're talking about the 2 top chambers, and when you're not really beating it well, the heart's not beating well, and then you also now have, let's say COVID, there's some kind of a compromise to your lungs, to just getting oxygen to your limbs. You said you saw a couple of them during this year, but not enough to where you thought, oh, we all really expected that strokes are going to be a thing with these clottings.
Right, I think that's what we expected, and I just don't know that we have enough data. I mean, we may very well find that's true, but I don't think the data's out there enough to really tell us that that was a big contributor. I still think it's lifestyle changes, choices. Young people also, they overexert themselves. They don't drink enough fluid. Their body their blood gets viscous, thick.
Ew.
And so that's the other thing. I mean, strokes can also be caused by lack of blood flow from a trauma, and you don't have enough blood flow going to your brain. Anything that's causing a lack of blood flow to your brain will cause a stroke.
Right. Okay. I want to bring in, and not that this is a heart attack show at all, but there are a lot of the same risk factors. There's a lot of the same types of issues for, we're talking about diabetes again, hypertension, just high blood pressure, cholesterol, et cetera. When you're looking at someone who is at high risk for a heart attack, does that kind of automatically mean they're also at a high risk for stroke? Is that one and the same?
In my opinion, yes.
Okay.
Yes.
Okay. So I'm asking you right now to just advertise to the people out there when you're driving here today, and you'll have a little chance to do this later too, of lifestyle. Because we talk about lifestyle, but what does that mean? I mean, even walking 5 minutes a day. I mean, it'd be great if you can do 30 minutes a day,
Right.
but feel free to just throw out there what people can do just listening to the show right now.
It's about healthy eating, getting sleep. And,
Oh, that's so easy to say. Jeez.
and some form of exercise. I mean, we all know it's hard to exercise. I have a very hard time exercising, but whether it be a walk, whether it be a bike ride with your kids, whether it be something, get you outdoors, let your mind think, and it also gets some physical exercise in there. So you don't have to start off with running a half marathon. Walk around the block, a simple start, walk your dog, go out with your kid, whatever. It's those simple steps that make the difference. Cut out that extra slice of bacon, cut out the extra sugar in your coffee. I mean, simple changes over a long period of time will make a big change.
And getting a dog. Years ago, I remember one of the doctors just said, just get a dog, and I'm like, what do you mean? Because you have to go walk the dog. You have no choice, so I kind of understand that too. Some questions here, it's like some sample questions for people that, says here, my mom had a stroke and they did a procedure through an IV instead of a normal surgery. What does that mean? What difference is it to do it through an IV instead? So read into that anything you'd like to read into it. I feel like you're a venous girl. And maybe we can talk about the blood thinners. I shouldn't call it that, but right away when you get there. Let's actually, Dr. Broomman, let's take that to you. So let's go back to, it was intravenous, but now it's a shot, but it's a one-time shot, not something that has to drip. Maybe we can talk about that.
So yeah, I think there's two ways to think about that. One did they actually do a procedure intravenously with, like, we're going to go up with a coil or a balloon and open up something, or did they just give the blood eating medication, the blood clot eating medication?
Okay.
So I think that's the two ways of treating it. Now, certainly, if you can treat them with just by giving medication, you're far better off than having to go in and manipulate within the brain. But sometimes those procedures are absolutely necessary,
Right.
and that's why we have such a great team to be able to go up and do that.
So when you do give a blood clot eating medication, I love the way you say that, how long do you wait for that to or maybe not to take effect in order to decide, okay, well now we need to go in and do something a little bit more seriously? Are you, like the CAT scan, do you take a CAT scan every hour? How does that work?
You can see it in the patient themselves.
Oh, you can?
They'll
So
start
describe that if you don't mind.
I've seen it multiple times where the limb will start to get stronger. They're able to speak to you. So oftentimes before they're even leaving the emergency department, after we've given the medication, you start to see a difference. They'll
So
be
you're
able to
talking a
speak.
matter of hours?
Minutes.
A matter of minutes? A matter of minutes?
Minutes, yes.
Oh my
You can
gosh,
start to see a
okay.
difference.
Okay.
And again, that's why it's so important, because the faster we get this medication to you, the more brain we save, and the faster you're going to be back to normal. So literally, I've seen people that cannot speak at all, and by the time they're leaving my department, within 90 minutes of everything we've done, they're starting to speak, they can move their arm. Oftentimes, even within minutes of giving the drug, while the Tele Neurologist is on, if it's a small issue, they'll start to see improvement right away. It's miraculous. It really is miraculous.
And when you say the Tele Neurologist, are you talking about a neurologist who's on the phone watching?
Yeah,
Because I think of telemedicine, I'm just thinking.
Exactly. They're on a big television screen, high
Okay.
definition. They're able to examine pupils. They're able to do everything with a very high definition camera. So now is not only the emergency physician, I have a neurologist on the television that's helping me decide, is this a patient candidate for alteplase or tenecteplase, either one. So it's very helpful to have two brains, especially a neuroradiologist that can take a look at the films and say, hey, okay, this is what I think needs to be done.
So if you don't mind, expand a little bit more on that and how that developed to what it is today. So obviously it takes time to get in your car, go to the hospital, and there's only so many specialized doctors here and there. Is that something that's going to be more and more commonplace in our world?
Yeah, I think that's very true. I think the ability to seek out specialists at a distance where you are underserved. So say I'm in Alpine. There's no way I'm going to have a neurologist there that's going to be able to do that stuff. But he may be in El Paso, he may be in Dallas. And now I can control that care, working together with that emergency room physician in Alpine to decide, I need to give this medication, rather than waiting 3 hours to get him flown to El Paso and all that brain is dying. So I think you're going to see more and more of that being used in, certainly in big cities, but in rural areas, I think it's going to make the bigger difference.
Yeah. So this is me being a technological nerd. So the camera's in the room, and the camera is high definition, or whatever words we're looking at it. And the doctor, so who's operating the camera? Is a nurse operating the camera? Is
The
it one of
physician
those?
on the other side.
Oh, he's
So
operating.
he's
the
able to zoom in, he's able to, look at the different parts of the body. Oftentimes the nurse is in there. Many times the physician is in there at the same time. Because like I said, everything almost happens at the same time. So everybody's doing it at the same time. I've started my NIH stroke scale, and the Tele Neurologist is seeing everything. So he doesn't have to repeat that scale that we use to measure this.
Okay.
So oftentimes it's, like I said, it's the entire team working at the same time. But the Tele Neurologist is there, and he's really the specialist to help us decide, is this a good candidate for TPA?
So how long has that been a thing? Are we talking 5-ish years? I think right now with COVID, all that's extra exaggerated, and there's so many things that we now do learn with COVID and efficiency with telemedicine and just the ways of doing things, but I can see that being something that's been going on for quite some time.
Tele Neurology, this is probably our second company that we've worked with, so it's been around, I would say 8 to 10 years. When we started it here in El Paso, that I recall, and maybe even longer than that. But the technology is getting better, the cameras are getting better, the speed of Wi-Fi is getting better, so as it grows, the technology also improves, and I think that just helps to shrink the time to treatment.
Wow. It's so interesting how all this works. I would like to talk about smoking a little bit, because I feel like smoking is on such a decline, which is fabulous. And I think years ago too, when we started doing shows about heart attacks and strokes, that was such a big thing we talked about. I think we're at we're at 16% smoking in El Paso right now. But talk about again, I think about physiologically, what is it that smoking does to the vascular system? Because I know we were talking about your specialty in the vascular system. What is it doing to the vessels, the arteries, et cetera, and why is that such a thing for strokes and heart attacks?
Wow. So I guess smoking, it's inflammatory, right? So it's going to cause damage to the vessels, thinning them out. It also increases your blood pressure. So these are all things that are kind of intertwined.
I always think to myself the hardening or the thickening.
Yeah, it's like fiber dysplasia. It causes this kind of
Fiber
fibers,
dysplasia, that's the word.
Big word.
little changes in the vessel that make it.
Yes.
And that's what I'm interested in hearing about is the changes in the vessels. So again, physiologically, what is happening to the vessels? Because smoking affects so many things. And that's why I'd like to somehow create a picture for the audience of what it is that it's doing to the vessels.
I think the way to think about it is they get less elastic.
Okay.
It's kind of a naive way, but it paints a good picture. They get less elastic, and they get tougher to work with. So they don't have the ability to flex to different conditions. I mean, normally your blood pressure goes up, the vessel gets a little wider, goes down, and gets compressed. So think of it as losing flexibility. I think that's an easy way to think of it. Maybe a little too naive, but
that's exactly what we need to picture in our heads of what it is that's happening. Because if you're looking at blood flow, especially if you're going up a flight of stairs and you got the blood pumping, you want to be able to have that elasticity there.
And while you say smoking is going down, that's very true, but vaping is going up.
Oh, God bless you for
I was
bringing
going
that
to
up.
say, yeah, vaping is a big thing among
it is.
And
20 and
nicotine,
30-year-olds.
yeah, exactly. So I think we've just replaced one evil with another,
Yeah.
and it's extremely addictive, as nicotine is. I mean, so.
And so I'm glad that you brought that up. So people would think, you know, it's the smoke, but it's the nicotine and it's also the 10,000 other chemicals that are in there.
Exactly.
So get on the high horse now, because I'd like to get on it with you. We passed the smoking ordinance in El Paso in 2001. So that's 11 years ago,
Right.
it seems like in that point. So vaping now, for a while it seemed to be that's what the younger ones were doing.
Right.
But now I'm seeing older and older people vaping, and you know, I think it was advertised for a while, well, this is how you quit smoking.
Right.
And now that's a whole nother new addiction. What are you seeing now? Since that's still relatively new, but as an emergency room doc or just a doctor in general and what you're reading, what is it that you're seeing now with people in the vaping, just all the consequences of vaping?
Well, I see predominantly still youthful people are mostly vaping. The older people still like their cigarettes, or they're trying to vape and quit, which doesn't work. So the biggest changes that we see is respiratory illnesses, and then you know, asthma, those kind of things. Now there are pulmonary diseases that are being thought of being caused by vapes because they have a high level of vitamin E in it, vitamin E acetate, and they think maybe that does damage to the lungs. So there are some actual physiologic changes that happen to the lungs due to the chemicals within the vaping material.
And that's just freaky to me. We have 7 whole minutes. So I've got a question here from the audience, and the audience member is taking Eliquis for preventing deep vein thrombosis, and they want to know, does this medication also help with preventing strokes? And that's a great question, because again, we're trying to think in our head of vascular systems, etc. And I know that we didn't say that there's a screening for strokes, etc. But is that just something that, like the 3 aspirin a day or the 2 aspirin a day, thrombosis, strokes?
Well, certainly Eliquis is indicated for people that have either a clot in their leg and have a risk of forming clots, or have atrial fibrillation and have the risk of throwing these clots. It's not a drug that we would put people on to prevent it, but those people that are higher risk, it's a great drug to prevent to lower the risk of a stroke.
Okay. All right, Sin, I'm going to do this because I try to do it before we get off the air. Is there anything that we have not spoken about yet this evening that you would like to talk about, get across to the audience? I'm going to come back to you and ask the exact same thing. Sometimes the show wraps up so quick and it's like, oh, I forgot A, B, and C.
No, I think we've covered a lot. I think just to reiterate, you have any kind of symptoms, even if it's just dizziness, and it goes away, you need to call 911. You need to be checked out. You need to go to the hospital. I mean, what's the worst they can say? You didn't have a stroke.
Right.
It's better than waking up in the morning and you can't move your side.
And if it's possible, and I say this because I know it's not always possible, but if you have someone around that can kind of watch you and say, hey, am I drooping? Am I looking funny? I'm feeling kind of weird. Could you notice that too? And what I've just heard from years and years of doing this program is often the person who's having the stroke is not the one that realizes they're having the stroke. It's the person they're with. And strokes are, and correct me if I'm wrong, they're painless. So you don't really feel any pain usually. So the person that you're with is the person who would see what's going on most of the time. Is that correct?
A lot of times that's exactly what happens. A family member notices a droop, or notice their speech is a little bit off, or they can't seem to focus on they're holding their phone and can't. So a lot of family members will notice right off the bat. And again, the key is that 911. Don't worry about driving them yourself. Don't worry about any of that stuff. Just implement the system, get stuff started.
And again, why is that? Because it's like a little driving hospital. That's how I always think of ambulance. And some doctor said that years and years ago. And it's a mini hospital. Granted, there's not all the things in that a hospital has, but there's a lot of stuff in there that can be accessed. And again, the important part too is there is an EMT, someone who has been able to speak to the person at the hospital.
Yes, you have a paramedic, you have an EMT, you have medications to control your blood pressure, you have medications that they can be given, oxygen that can give you more oxygen to your brain. So and they can drive really fast.
Yes, exactly.
Legally.
They can go through the lights.
Legally.
Right.
So I think that's the whole idea. That's why the EMS system was set up, and that's why it works so beautifully. It's just a lack of use or feeling like you're going to impose. You're not imposing. That's what the system is there for.
Exactly. Exactly. On that note, what is it that we haven't spoken about, or something else that you'd like to reiterate before the questions wrap up?
I think our biggest help has been teaching children how to notice that something's wrong with grandma or mom or dad. And so we really need to teach our children about B.E.F.A.S.T, because they'll often notice something's wrong with grandma or something wrong with my aunt. And so I think we need to take advantage of teaching this. We've taught it to adults. We need to go out and teach it to our children in our community.
Yeah, I feel like I'm giving you guys a quiz. So B is balance, E is
Eyes.
eyes, F is
Face.
face. Face drooping. You're so cute. You made your face. A,
I know we're like me.
it's like we're going through it now.
Arm or leg.
Arm or legs. And then the S is for slurring
Yeah,
or
speech.
S slurring and speech. And then the T is time. Everything
Time
is
is brain.
all about the
Call
time.
911.
Time is brain. I almost don't want to ask you another question because we're starting to run out of time. But again, just be fast. And I'd love for you to just, if you guys go on websites, and this is such a big thing, if you go on a website, see if you can find it ending in an .org versus a .com. That makes such a difference when we're looking at medical stuff, because Dr. Google isn't really a thing. Dr. Google is a .com. You need a .org to help out with a lot of these symptoms. And if you want to watch this show back, because a lot of times we do speak so fast that it's hard to catch up, but there's 2 ways to do that. Actually 3 now. You can go to YouTube and do PBS El Paso and look up something called the El Paso Physician, which would be this. You can also go to kcostv.org. It's also pbselpaso.org. They're both tracking with each other right now, but it's probably better to get used to pbselpaso.org. And when you do that, just go to watch programs and find the El Paso Physician. You can also do that through the El Paso County Medical Society's website, and that acronym is EPCMS. Just think of El Paso Medical Society. And that one, however, is a .com. I have a quick question from the audience: is Bell's palsy and stroke, what is the, you know what, we don't have time for that though, but do you want to like,
Two different things.
2 complete different things, that helps out quite a bit actually. Madeline, I want to say thank you so much to you. I know sometimes it gets really crazy over there, and I'm looking at my text messages, and that's really the questions that are coming our way. And I want to really quick, because you touched base on this, we have like a whole minute left. Glio cells, tell me again what that is. So when you're talking about every minute you lose glio cells, which is holding that together.
There's 2 major cells in the brain. There's neurons, which are doing all the electrical work, and there's glial cells, which are just construction work.
Okay, so
keeping
they're
the
holding
cells
them.
in place. So I mean, both of those are neurologic cells that you're losing. So whether it's structural or whether it's the conduction ones, they're still both very important.
Okay, so that's something I'm going to look up for the next time we have a stroke show, because to me there's so many questions just around that and the timing, because when you're looking at the 10 cc's and you've got the, you know, every minute there's a loss there. So we've got 30 seconds. I'm going to wrap up again. kcostv.org or pbselpaso.org or epcms.com, and that will get you to see this show again, and plus all the other shows. I mean, there are shows, if you want to know about knee replacements, you'll find that on there as well. But I appreciate you watching. Thank you for the El Paso County Medical Society. Thank you to Tenet. I'm Catherine Berg, and you've been watching the El Paso Physician.